I see a lot of familiar faces. I think even Dr. Ames, I was a resident when you gave presentations at Hopkins in Baltimore a long time ago, so everyone's still the same. So I had trouble titling this talk. I initially was going to call it percutaneous prone lateral. It's basically, this is kind of a little bit avant-garde, a little bit off the beaten trail. I've been trying to do more of a endoscopic, percutaneous, whatever you call it, approach and trying to develop that for a lateral. But that percutaneous prone lateral turned out to be PRP LLIF, so I put retractorless as well. I think Jeff is the one who pointed that out. How do I move forward with this? Is there a way to move forward with this? It's not. No. Do you want to just hit it then? Just the next button. I don't even know if it's on present. Is it on presentation mode? Yeah. You just hit next, maybe. Yeah, there we go. And hit. So yeah, just some disclosures next. Okay, so yeah, when I kind of sought, or do you want me to bring my laptop up here? Or is there anything I can do to control it? Okay. So yeah, let's just go back one. So, oh no, go forward. So when I first started, I started with the AlphaTech lab, and this was like a prone lateral and a cadaver, and I started this was a cool picture just because there's a stent in here and in this patient, and you can kind of see like the anatomy of the iliacs and the aorta are all in front of the spine. So theoretically, you could actually, with the percutaneous approach, do every single level, even L5S1, if you really were brave, or go transiliac. Let's go next. Oh, try it again. Okay, now it works. Perfect. So yeah, this is just some of the early labs, and then I started working with one of our general surgeons to try to try to approach the retroperitoneal space. I tried insufflating, it really didn't work. It was just simple. You could just go with a trocar, with a general surgery trocar, into the retroperitoneal space. You can see on the left the camera. You don't really see anything. It's just kind of peach colored. But I know the urologists insufflate the retroperitoneal space pretty routinely to get into the pelvis. So, that potentially could be done in the future. But, here we were just using navigation and trying to just get to each of the disc levels. And eventually this is just very early on when we did this. But eventually I used the Globus system with the IntraLIF cage. They actually have an on-label indication to go lateral with it, even though it's really it's actually an oblique T-LIF cage. But, this is here I was just pointing out in a case. If you put the marks on the patient, if you're doing a navigated interbody, L4-5 usually falls underneath the iliac crest, which is what that demarcation is. L1, L2, L2, L3, L3 or 4 easy, straight lateral, and then L5S1 is through the iliac crest. But these are kind of just some of the first cases. This is where I started to understand, do I need to actually do dissection and with finger dissection to do this, to get to this space in an endoscopic fashion? And you still do. With the thin patient, the colon still, their descending colon still in the way. With an obese patient, sky's the limit. There's the colon and all the guts are all in front, so you can actually just go straight endoscopic without even finger dissection to each of these spaces in a navigated fashion. But we're trying to develop new access corridors, either through the iliac crest or the traditional way, as you can see on the top, is going over the iliac crest. Can we go through? And the answer is you can, but the holdup is the interbody size, the instrumentation ports that you have to use. So I first started using the Globus IntraLIFs to explore this possibility. Again, it is an on-label thing that they have approved. But with the percutaneous prone lateral, I just do finger dissection. I think Casey, I was the first year I started, that he was with me in my first year I started doing this. And I was always very afraid of the lateral. I mean, I was really a T-LIF surgeon, an A-LIF surgeon. I was more afraid of the lateral because of the nerve palsies and psoas retraction time, et cetera. This actually has solved a lot for me. Since I've been doing these percutaneous prone laterals, I've really have had no patients with any of these psoas injury, or definitely no femoral, but not even psoas pain, because you don't retract on the muscle. And the incision is relatively small. You can still, through these tubes, you can still get out discs, no problem. And I just wanted to show you just a case or two, just to show you how it's working for me. Basically, a doc with an invasive dilator, neuromonitoring dilator, insert a K-wire, and then just kind of snake into the disc space. And you can, then they have a system where you up-dilate, and then you clean it out with a shaver, with pituitaries, articulating curettes, a metal brush, and then you can see in the middle and the right, I put in this lateral cage. Again, I acknowledge that it is small, but you can actually get some pretty good lifting power with this. And it makes the surgery fast. It takes 10 minutes skin to skin. I can get L3-4, L4-5, and through one incision easily. I can go all the way up to L1-2. And it's been a nice little workhorse. Certainly it's not as sexy as like a huge cage, but from an anterior approach, it's reasonable. And as long as if you put it right in the end plates and don't violate end plates, you don't really get that much subsidence of these cages. Here's an example of a 2-level I did, and through a percutaneous prone lateral. And this is kind of what it looks like. And it keeps the workflow is nice. The OR staff likes it. You get the advantage of the prone without the difficulty of using your retractor in a prone position. And you do it on their x-ray guidance. You don't actually have to do it. You don't do direct visualization. Here's between some two fusion constructs. That's kind of what it looks like. I try to get a little angulation. Again, it is a glorified TLIF cage in this case. But you get the advantages. You get to put it more anterior. And by doing that, you get a little bit better lordotic correction. You can see on the picture on the left, that's a collapsed disc level. You can kind of snake this cage in there and pop it open with the IntraLIF. It really does expand the height and the foraminal height, so you do get the same indirect decompression as well. You can really control it. Like, so this one, I actually accidentally put it a little anterior, and it just stayed there. It didn't. Even if you open up the ALL and break the ALL, it doesn't. The cage actually will stay there because you're really disrupting just the corridor for the disc. On the right side image, there's a DRG stimulator. That was actually a project that I worked on way back when I was at Stanford. I did the founding IP for dorsal ganglion stimulation. It's just random, but that kind of works. Here's the size comparison of the IntraLIF with the standard lateral cage. Obviously, a lot less bulk, a lot less mass, and that's what makes it easy. Here's a case where I did the posterior approach and I did the lateral at the same time to just try to see if I can control lordosis with a simultaneous exposure, and it worked. And then here's a case of, I'm not here to say that this is something that can correct scoliosis by no means, but in this case, there was just a degenerative scoliosis patient. And when we put it in, you can see on the left, pretty collapsed disc spaces. You can see a lot of rotation in the spine in the middle and the pre-op. And post-op, you can compare on the left, pre-op, post-op, on the middle, and on the right. It does a reasonable job of doing a simple correction. And here's a case where you can go, we went trans-iliac to L5S1, and you can get in there without any disruption in monitor, or any change in monitoring. This is a case I think 3 months out, or 6 months, 3 months out, and you can see even with, this was for an adjacent level extension, and even with a larger construct sitting on top of it, the cage wasn't subsiding. So if you look at the market for there's posterior lateral oblique, they're all pretty big retractor-based approaches. I do think that this does minimize the footprint. And it's great, but the only issue is going to be with expandable cages with a small footprint, you're going to get subsidence, as we know, compared to statics. So one of the things that we've been working on is this. It's a stents-based structure. It's a 288 cobalt chrome braid made with the guys here who did the web, microvention web, locally in Aliso Viejo. Through a cobalt chrome braid, we put in about $7 million into this project. And basically what we do is we fill it up, and it actually supports 2 tons. And it actually is equivalent to an ALIF or a lateral cage. But the idea is you can still use a 5 millimeter, 6 millimeter delivery trocar, or 7 millimeters, and get a pretty large implant in with the lordosis. And I'll show you how that works. But it's expandable HA peak, cobalt chrome dense braid, and we're working on titanium braids as well. This is what it would look like. You would have, you can see compared to the ALIFs in the bottom, on the top, you can actually get a triangular shape. It just basically molds to the shape that you give it, and the port size is that little circle. But again, it gets the ALIF lateral size. But the real key is the fact that you don't need a retractor. You just put it in there and it holds. You can also theoretically do this through a robot, and we've done some Mazor labs with it as well, and it's good for navigated placement, especially with the new Stealth coming out. Under subsidence, you can see the this interbody cage is called Bloom for now. It's equivalent to a ALIF subsidence or a lateral subsidence. Compared to spinology, which people usually draw analogies to, doesn't really hold much weight, only a few hundred pounds, and it starts collapsing. The 3D CT of this shows you have interlocking HAP scaffolding with a surrounding braid. This is what it would look like in the disc space with the multi-layer scaffolding, almost palisading here. And it's really drawn from this kind of the dynamics are called granular dynamics. It's drawn from what we saw with seawalls with interlocking geometry, and those things can sustain waves and waves of years and years of pounding waves. When we do our 5 million cycle fatigue testing on this actually actually does pass 5 million cycles, so it actually holds up to what other, similar to other implants, and that's something that spinology wasn't able to hold up to. So it's a much stronger version of that. This is what it looks like in cadavers. These are from some of our very first ones where we put it in, and you can clear the disc space percutaneously, and then you can put in a square implant like that. And our newest iterations of discectomy devices are even better. This is a sheep study we did in Montreal. This is where the bone intercalates through it, and you can see the 3D CT. There's bone growing on the left, and there's a little bit of void on the right. This is just with autograft. But it does grow through and through the braided structure, and it grows around the peak to interlock it. This is the animation of what the procedure could look like, or would look like. And first, the idea was we would look and try to put in screws first, and then follow that on with putting the interbody. The interbody, we would clear it using neuromonitoring to clear the disc, to first dock, just like a traditional lateral, and then we would try to clear it with articulating tools. And we have a few articulating tools that we've been able to develop. That's just a punch, essentially. We have these kind of articulating tools to clear out the space, followed by a brush, the same, and then we have a pituitary that goes through a 6 millimeter port, articulating curettes, more cleaning, and a brush. And then the other thing we borrowed from vascular is this balloon. We use a balloon that's non-compliant. It's different from a kyphoplasty balloon. This thing can hold thousands of pounds of force and actually change the shape of the spine as well with the balloon. And we can control that to make that either distract. In this case, if you just do a partial torque with 1 Newton meter, you actually distract. You allow it to inflate and distract with lordosis, I think. And then you can. Oh, that was just distracting vertically, and then this one is distracting with lordosis. And then you final tighten that down, and then you put in the braided stent. And then you cap it at the end. This animation is too slow, but but then you put a cap here, and then what's interesting about this is you can actually dial in the degrees of lordosis. Think of it about in creating in situ lordosis. Carl's Med and everyone are trying to do like custom implants, but here you can actually dial in the lordosis you want. I'll skip these. These are just workflow times, reducing the interbody time and turnover time. This is kind of like a video showing the difference when you have a structure that has a kind of granular mechanics. It doesn't press into the bone as much as some of these solid devices, especially the ones with the big graft windows. And but then the difference was, and that was what spinology was supposed to intend to, but the problem is spinology mesh was bone graft, which doesn't really hold as much under weight. This is an example of a lordotic-shaped L5S1 interbody. This is the last few slides. This is the balloon. This is if it distracts without any locking, but if you do a partial lock and control that distraction and just let it rotate and pivot, you actually get a balloon that allows for just pure lordosis. And you get still indirect decompression with pure lordosis. And then you can dial this in because you're just lifting up that balloon. This is the balloon overcoming fully tightened invasive screws. And the idea eventually here is we might be able to get a pressure component and some sort of intelligence on the amount of expansion we're doing based off pressure, so it prevents the loading of the next level, or overloading. The Japanese literature showed that. So I think that was it. This is the, in real life, that's what it looks like. It's woven off of a spindle. We hope we can use it with robotics. And this is just, I'm just going to show here what it looks like in real life. the idea is eventually we'll be able to do navigated approach. We can do percutaneous access to the disc. Again, the footprint is pretty small. There's no retractor. And then you can clean out with various tools, including wire brushes, expandable brushes. And then and ideally we want to make it all fully disposable. We're working on doing that. Our current system is all fully disposable. It should expand and read out a PSI just like a kyphoplasty. You can hopefully read out degrees. We can read out degrees if we actually just track him, and then you insert the implant. And then this is what it looks like when you're filling it with the peak particles or HA peak particles, and then you lock it. And then that's what it is in 3D and AP and lateral. And you get like a lateral size footprint. It's a little better than the IntraLIFs I'm using right now. And hopefully we'll be able to launch soon. It's currently in FDA right now. And that's it.